Welcome to the Ross University School of Medicine's Procedural Skills IV Catheterization Lecture Presentation. I am Dr. Brenton Otey, and I will be guiding you through this lecture today. Let's go over some of the objectives. We expect to provide students with a framework for performing clinical procedures on patients, provide students with basic considerations regarding IV catheterization and phlebotomy, and provide students the opportunity to practice IV catheterization and phlebotomy, common clinical skills performed during clerkship rotations. Patient communication is incredibly important, not just in this procedure, but in all procedures. Ensure that you communicate with the patient that you'll be performing a procedure on them. Components of the communication include the following: an introduction, what the procedure entails, giving the opportunity for the patient to ask any questions, and then as you finish, make sure that you recap so that the patient has a complete understanding of the procedure and everything that you've discussed. For the patient-specific pre-procedure component, ensure that you have the correct patient by verifying their identity. You can do this with the EMR, the ID band, verbally asking their name, and confirming with the picture ID as well. You also want to make sure that the insertion site is appropriate for the procedure that is established. For IV insertion, the patient may be admitted to the hospital for a number of days, and site location for ongoing IV therapy is critical. You have to ensure that you change sites to avoid infiltration, phlebitis, etc. And other concerns are female patients with a history of mastectomy and fistulas, and so on. Another tip: while reviewing the patient's EMR, check for previous procedures, as it may indicate previous locations and influence your site selection. There's quite a bit of equipment that you will need in order to perform a successful IV cannulation. These could include the Chuck's pad, the IV catheter, alcohol wipes, a tourniquet, some IV tubing, IV solution, a flush, the HEP block, some gauze, tape, tegaderm, and a kidney basin. And avoid equipment containing latex if the patient's chart specifies that they have a latex allergy. Always remember before you start to wash your hands and don a clean pair of gloves. Now you will assemble your equipment. Ensure that your IV bag and tubing assembly is ready to go. You as the physician will most likely not be the person doing this directly, but it is still an important process to understand, so I'm going to leave the slide in here for completeness sake, but move forward. Make sure your HEP block is assembled correctly. Connect the pre-filled syringe to the HEP block and flush the HEP block with the IV fluid. Ensure you have the injection port readily available. Then take the supplies and go to the patient's room. For preparation, when you are placing the tourniquet, you want to first inspect the arm for any contraindications to site location. This could be areas of inflammation, bruising, the presence of a fistula, a broken skin, or sclerotic or thrombosed skin as well. Now place your tourniquet and check for veins. Now we are going to prepare the insertion site by cleaning it using a clockwise application of the alcohol swab, starting in the middle, moving outwards towards the edge. Do not touch the site after it has been cleaned with the alcohol, as you may reintroduce bacteria to the cleaned area. Prepare your tape. Ensure that there are 3 strips of tape available, no more than 4 inches apiece. Check your catheter, ensuring that it moves effortlessly of the needle. Prepare the patient by asking them to hold their arm down and to make a fist to help the blood pool in the veins. Now for your needle insertion technique. When inserting the needle, make sure that the bevel is pointing upwards and you're going in at a 30 to 45 degree angle, maintaining a steady angle throughout the whole process. Ensure that you have a flashback of blood. Also, make sure that your needle stays in place when advancing the catheter forward until the hub reaches the skin. Remove the needle completely out of the catheter before applying pressure to stop the bleeding. When dealing with sharps, if the catheter has a safety mechanism which would protect from the needle point, ensure that it is activated. If the catheter does not have a safety mechanism, place the needle into the Chuck's pad fabric. This will help prevent inadvertent exposure. For the hep lock, we're going to connect the hep lock assembly and partially draw back on the syringe to ensure that the vein is still patent and can accept fluids. You should see some flashback, which would indicate that the vein is still successfully cannulated. Flush the vein with the saline syringe, clamp the hep lock, and then remove the syringe and connect the injection port. Lastly, you're going to clean the site if any blood has spilled on the patient's arm or hand, and clean the site using both gauze and an alcohol swab. Supply the tape and the tegaderm to secure it in place, and then dispose of your needle in the appropriate sharps container. For the post-procedure, be sure to document it in the EMR, including time, procedure performed, site location, medications if they were administered, site appearance, patient tolerance, and any additional steps which were taken during the draw. There are, however, a few possible complications which could arise, which you need to be aware of. A hematoma caused by the blood leaking from the catheter insertion site. Management of this would include discontinuing the IV and holding direct pressure on the site for several minutes to prevent further bleeding. You could also have an instance of infiltration, which is caused by the IV fluids leaking into the skin tissues at the catheter insertion site. Management here is also to discontinue the IV. Any procedure which causes breaking of the skin barrier poses a risk of infection localized to the IV insertion site. This could be due to invasion of infectious organisms into the IV site, inadequate aseptic technique when initiating the IV, failing to protect the point at which the catheter enters the skin, or failing to use good aseptic technique when piggybacking another IV solution or changing IV solutions. You can also have possible necrosis. This usually occurs after an infiltrated IV causes tissue death, i.e. necrosis, to the area of the soft tissues around the leaking IV site. The necrotic tissue will eventually begin to slough off, revealing raw, opened wounds. The management here would be to discontinue the IV, bandage the wound area using aseptic technique, and then transport them to a location where they can get further treatment. In terms of IV removal, if the patient is going to be discharged, you may need to remove the IV prior to them leaving the hospital. This step is usually done after the attending physician has properly discharged the patient from the clinical care. Once the final tests have been conducted and the patient has no indications for any further stay in the hospital, discharge orders will include the removal of an IV and other therapeutic measures as well. For your IV removal, you always have to gather your supplies. This should include your gloves, alcohol swabs, gauze, and a bandage. The steps are pretty simple. Wash your hands, place your gloves, and then you are going to use the alcohol swab to remove the tegaderm or tape if they have hairy or fragile skin or if the patient's demeanor indicates sensitivity. Then you'll place a bandage over the IV site after it has been removed. If you find yourself to be more of a visual learner, we also have 2 slides of supplementary information regarding the IV cannulation technique at the end of this presentation.